It is my great pleasure to introduce a friend and a colleague for over 15, 16, 17 years.
Hi, sweetie.
I don't call her sweetie, but I might start calling her
Sorry. That's my granddaughter.
No, I totally get that. I was just thinking for Sevia, an appropriate friendship, but our relationship and our friendship goes back to many studies that we've collaborated on, some of which you've heard of or maybe even done analyses in, including the Ginkgo evaluation of memory study, the Women's Health and Aging study, and among others. And what's exciting about Dr. Yasar, and it's a pleasure to introduce her because she won't tell you, but she's actually an MD, PhD, and she's basically a triple threat, really, in terms of her background and her work in epidemiology, her obvious clinical chops as an associate professor in both the Division of Geriatrics and in the Division of Neurology here at Johns Hopkins. And she has a PhD in pharmacology, which has been really exciting for us and our collaborations to really learn a lot on the interaction of lifestyle, for example, and pharmacology when we think about preventive interventions using observational data. So it's been a great pleasure to work with her in those areas. And I think that it's important to know that there's those many layers to Dr. Yasar's background. And today you're going to be hearing more about her clinical acumen, but I think it's also feel free to kind of ask her a question or two about her pharmacology degree and her background. And with that, Dr. Yasar, I'll pitch it to you.
Thank you, Michelle, for the kind introduction. And yeah, my heart goes out, and of course, my thought and prayers to Karen's family. And definitely, this is a hard time. So let's get started. Let me share my screen.
Sevia, I wonder if it's okay to ask, it's probably the best time to ask you, would you like to hold questions or would you like questions as we go along? Because I'm happy to follow the chat if you'd like to hold them, we can do that.
No, it's fine if you get it in between, I have no problem.
Okay.
So I'm fine in between. Can you see the slides? Okay, good. Okay. So I was asked a little bit today to talk about my clinician. Do you mind if I take off my mask? We have plenty of, it's just easier for me to talk. Clinician research perspective on cognitive aging decline in older adults. So disclosure, I'm a researcher, as Michelle Carson said, and I study vascular risk factors and vascular risk factor modifying medications and how they can lower dementia risk. But today I'm here because I'm also a clinician, and I was asked, to show you a little bit how my world as a clinician works. So what I do in my clinical work, I evaluate and treat patients with memory disorders at the Johns Hopkins Memory and Alzheimer's Disease Treatment Center, but I also evaluate and treat patients with possible normal pressure hydrocephalus disorders who have both memory and gait disorders at the CSF Center. I'm sorry, I apologize for this teddy bear, but I think you will see I liked it, and this will guide me through this talk. So very often when people come to the clinic, their question is very simple. Do I have dementia? Yes or no? It's that simple. And it's actually interesting. In a kind of sad dementia diagnosis in a clinic, the estimates of undiagnosed but existing dementia range between 25 and 90%. So approximately what we think 50% of the people have actually undiagnosed dementia, and it's not always the mild cases are missed. And the undiagnosed dementia is usually missed in older people who are living alone and who are poorer. And why are these diagnoses missed? For quite good reasons. First of all, patients, they can minimize their symptoms. Early dementia makes it kind of the criteria make it difficult, particularly when they come without, let me move it. 1 second. I have to Okay. Particularly when they come without an informant, particularly when these patients, they have very good social skill sets, they are fluent, and it's not always easy to, to pick up. Sometimes it's the attitudes for the family members, like there's still a stigma of dementia diagnosis, or it's a culture, it's normal in some cultures that you're forgetful. It's okay, we don't need to label someone, it's just part of aging. And there's the attitude of the care, the providers. Why should I diagnose someone? There's no treatment, why should I even, bother a family with that? There's also the lack of knowledge very often among providers, so they don't feel comfortable to diagnose and treat. And there's very often knowledge deficit among patients and caregivers. And of course, there is the cognitive tests, which are imperfect.
There's a question from Rob.
Yeah. In the chat. Okay. Oh, yeah. 2 questions. Ravi. Oh, yes. Yes, Ravi. Yes, it is true. There was a study done and it's that high. And it's not only as I said, it's not only the mild, it's also sometimes moderate. And it's the majority of the people who are diagnosed with dementia, it's in the primary care setting. So it's not the people who come to the memory clinic, but the majority of the people are diagnosed in the primary care setting. So, and you just imagine, I will come to that. So, but yes, it's correct. There's data about that. So this is the dream setting, and I talk about that. This is the dream, the research setting. And this was actually my breakfast before COVID, when I was on vacation. You can see it's all the details, a lovely raspberry, beautifully presented, flower, looks super healthy. So this is like this is the research setting when you have all the tools for dementia diagnosis. You have the time. Usually a research subject comes in. You have 2-3 hours. You have all the tools. You have multiple cognitive and functional tasks. You have questionnaires. You have an informant. You have the patient. You have also additional information. You have maybe gait testing, you have depression, and you also have additional biomarkers such as imaging, blood, CSF, cerebrospinal fluid. And at the end, you have a lot of smart people, a multidisciplinary team for dementia adjudication. And even better, you have like longitudinal data. So you have not only one time point, but you follow people. So you really have a better sense where the patients stand, and that helps you with the diagnosis. I think I have more questions coming up here. Should I answer them? Depends on culture, but.
Follow-up references. I think you can go ahead.
Okay. Yep, Dr. Amjad, I agree. Exactly. And Dr. Amjad papers is actually, she did that on NHANES. These are people who were not carrying diagnosis. And she just looked at people, when you look at the function based on the instrument or activity, daily living, and who had some memory problem, but they didn't carry the diagnosis. And just based on that, they would fit the diagnostic criteria of dementia. And she did that. And yes, there would be definitely a much higher diagnosis of dementia. So that was a very good paper by Halima Amjad, one of my colleagues. Good. I'm glad everyone is on top of that. So this is the research environment. Now let's come to my reality. And this is my general breakfast, still healthy, Greek yogurt with some blackberries, but a much more, simple. So in the clinical environment, that's my reality. So the one major limitation, and it's time. So if we have, I'm not complaining, for a new patient evaluation, and let's talk about the primary care setting. If we are lucky, we have 60 minutes. If we are not, then we have 40 minutes. A general follow-up visit is 30 minutes. In the primary care setting, we shouldn't forget we have for memory evaluation, it's only part of many medical problems. We are lucky now, Medicare now covers an annual wellness exam. And one question addresses now memory loss. I'm lucky because I work in a memory clinic and I have the luxury for a whole visit focusing on the memory. And I have, like, for a new patient, I have 40 minutes and for follow-up 30 minutes. However, very often there are other issues to address: legal, financial, social, and of course, behavior. So definitely there's the time issue. In terms of tools, the gold standard usually is when we see a patient for memory, and I'm now focusing it, when we really start to focus on memory, is a very detailed clinical evaluation, a very detailed interview of the patient. And I'm, again, in the memory clinic, I'm lucky because I have 90% of the time I have an informant. Then there comes the clinical, a cognitive test, and of course, the functional assessment tools. So I know it's not part of the cognitive testing, but it's very interesting. Again, research has been done, and it has been shown that most dementia is recognized because an informant's concern. Sometimes people, they're worried because they had a family member, they come on their own, but most dementia cases are recognized because a family member got concerned. And the pretest probability of dementia when an informant is concerned, it's actually not, it's 60%. So in people over 65. And even if dementia is not diagnosed at the time of the visit, it's highly correlated within 5 years, 45% incidence. So the incidence of dementia is 45% within 5 years. Additionally, an informant report is highly correlated with mini mental status exam. So we should listen. We very often, we listen to those informants. So cognitive tests. As I told you, we are very tight in time. So we doctors like brief, structured cognitive tests, which helps to classify people. Do they have cognitive impairment? Yes, no, of course, either mild cognitive impairment or dementia. And actually a study, and which was published in the Alzheimer's and Dementia Journal, showed that cognitive tests are actually better than just us doctors to determine if someone has cognitive impairment, yes or no. Cognitive tests has a sensitivity. They're better in detecting cognitive impairment. They're sensitive 83%, while clinician, as we showed, are not as good when compared to the cognitive test. So cognitive tests, as I mentioned, we like them to be brief. We like them to be validated. We like them to be easily administered by both a physician, a non-specialist, and also a non-physician clinical staff. For example, in the memory clinic, I'm lucky because we have nursing staff who does the cognitive test before I see the patient. Although I find it also very useful when I do the cognitive testing, because I see very often when the patient does the testing, why they maybe don't do well, they don't hear well, or they give up. It's maybe when they are depressed or they are impatient. It's very, there's a lot of information in a test. So it's important if you can do it too. And of course, it would be nice if it's free of charge. As of late, for example, the Montreal Cognitive Assessment, they are charging us, and even the mini mental, the MMSE, we have to pay copyright fees. And we love to have high sensitivity and specificity, which means we love anything above 80%. So I know you know it all, but for those who are not really in the area of cognitive studies, just the mini mental state exam was developed by Folstein, and it's the most commonly used, most translated, and the most studied instrument. It's used, although not developed for screening with limitations. It's also used to monitor whether cognitive function is declining and to follow the effect of treatment. Issues, as I mentioned, it's not originally intended as a diagnostic instrument. It's spuriously low in people with low education, with physical impairment, vision and hearing loss, with poor language skills, and also in minorities such as African Americans, Hispanics, and other minority population. Often misclassifies minority authors as demented. Sensitivity, specificity, it's a little bit low depending on what cutoffs you use, although specificity is a little getting there. The Montreal Cognitive Assessment, when you use a higher cutoff, which 26 is quite high, it has a high sensitivity for mild cognitive impairment and definitely for dementia. When you compare Miniment MMSE to MoCA, I use the color scheme. The blue is good and the red is bad. So Minimental, it's easy and fast to administer. MoCA takes a little bit longer. The Minimental, it's widely used and studied. The MoCA tests more domains. It tests visual, spatial, abstraction, language, attention, delayed recall, and orientation. The Minimental has, as I mentioned, a lot of biases. MoCA has also education bias. The Minimental has a ceiling effect, so highly educated people may pass even when they are cognitively impaired. Of course, with the Minimental people performs well with people with moderate impairment, people who have moderate cognitive impairment. So maybe that's good. You can still do tests in people who have moderate cognitive impairment where you want to follow them. So this was for general practitioner cognitive impairment. This was developed specifically for the general practitioner, for screening and validated for primary care. It has two parts for the patient and caregiver. And it has actually, when using both the informant and the primary care tool, it has quite a good sensitivity and specificity. And it has a good positive predictive value. It has little or no education bias, and it was translated in multiple languages. And this is the questionnaire, very simple, the patient part. It checks your memory, John Brown, 42 West. It asks you what the date is. It asks you to draw a clock. Can you tell me what happened in the news recently? And then recall the name and address. And in terms of the caregiver part, it asks you, over the last 5 to 10 years, does the patient has difficulty remembering events, conversations? Does the patient has word finding difficulties, managing finances, medications, driving? So it includes, activities, i.e. the instrumental activities of daily living, but also some memory related questions. So I can see why this has a good sensitivity. The other one is the mini-cog, which is suggested to be used. So it has also, again, similarly to the other one, the GB cog, it has a clock drawing part. Then a controlled learning. They ask you to learn 4 words: history, factory, policeman, and toothbrush. And you have to learn to tell me as many the animal naming in 30 seconds. And then you have to do the delayed, free recall of them. And then you score it. So that's the mini cog. And last but not least, again, a screening. It's the MIS, memory impairment screen. It's very simple. Basically, you have to have 4 words. The Red Cross, saucer, chest, telegram, must be an English one. They show to you the words, and 5 minutes later, you have to recall them. And you get 2 points for free recall and 1 point for cued recall. Again, it has little or no education bias. It doesn't test executive function or visual spatial skills, only memory. And anything, if you have a score any below 4, it has a sensitivity of 80% and specificity for 95% for dementia, and particularly for Alzheimer's disease. So clock drawing tests, we all know that quite well. It tests visual spatial construction and executive organizational abilities. The mean sensitivity and specificity is again 85. Again, it still has some bias, but it's a little bit less to education, language, and culture than mini-mental. I don't know with this new generation, maybe that will go out. Maybe in another 30 or 40 years, the new generation doesn't know what the clock looks like. So, but currently it still works. So let's assume I did the interview with the patient, I did the cognitive screening, and I even have a brain imaging. So, you know, here's the classification for Alzheimer's. It has to be gradual onset, you have to have some decline, and it has to be a significant decline from baseline. And I know I mentioned many, many times, it has to, you know, it has to interfere with your ability and function at work and use your activities, which is what they mean, IADLs, instrumental activities of daily living. And I brought this in, although I'm supposed to talk about cognition, but I had a nice chats, and I'm a mentor within the EBA of Emma Nichols, and she reminded I need to bring this in because it happened to me in the clinic many times. So IADLs means that defines if someone actually, you know, you need that in order to get dementia diagnosis. So IADLs means the use of phone, shopping, food preparation, housekeeping, laundry, transportation, medication, and finances management. But I mean, in the EBA, we are all from many, many different cultures, you know, and Emma reminded me, she showed me her research, but I mean, I'm from Hungary, I came from Hungary. When I came to the US, I never had a bank account. Hungary was a cash-only country. So I learned how to sew. My mom, again, from Hungary, she never drove a car. So we need to take these into account when we talk about IADLs. And I'm sure many of you can bring up many, many, many examples. So when I see people in my clinic, I see people from many cultural backgrounds. We need to take those into account. And I see people from cultures where the man takes care of everything. So I cannot always judge if she never took care of the finances, if she never drove a car, so everything is relative. So in addition, also there are geographic location difference, you know, urban location is different than maybe a farm. So Alden, okay, I missed some. Alden, invented mostly because many started charging, and now they charge for that. Yes. Alden put in a note in the bias and mental status like this. There do exist education adjusted adjustments. Some studies may consider different cutoffs. Yes, you're right. And even in the MOCA, you get an extra point if your education is below, I think, I don't know what grade, but you get an extra point. So, okay. So we need to take into the account with the IADLs that there are cultural differences and you know, geographic location. Okay, let's move on. So we made the diagnosis. I decide to treat the patient with one of these non-perfect medications. And I want to follow up if the medication actually does anything. Is the medication effective, quote unquote? So what about the cognitive tools we have, you know, to measure treatment effect? So none of these, what we went through, the, you know, the MIS, the mini-cog, the GP-cog, clock drawing, they were not developed or not used for follow-up. So what I have, which is very limited, is mini-mental and mocha for my clinic. So it's kind of a little bit remind me of my little poor yogurt. So the studies show that the yearly decline is, and the most studies were done actually for mini-mental, the yearly decline is approximately 3 points for Alzheimer's disease. Actually, in mocha, there are very few studies, and I've found only one study which shows that the yearly decline is around 1.74 point for MCI. There were very few studies with longitudinal data, and there was only one study which followed people for 3 years who had MCI. So that is kind of what we know in terms of what the yearly decline is. So if you have someone who's taking a medicine and they continue, of course, it's not only the mini-mental, but what the points a year, then obviously the medicine is not doing anything. So, but we need to have some tools which can help us to guide us in terms of, again, tools which are brief, easy to administer, and validated and sensitive to help us to follow this treatment, effect. And of course, it's the, Alzheimer's disease is not a linear, it's exponential. So people will decline faster at the end, towards the end of the disease. Again, there are no long, as far as I know, and Alden and Michelle, correct me, the decline is much faster, but I haven't seen any longitudinal study which follows them for a very long time and tell what is the change towards the, the end.
There's some studies in Ross Map that have looked at like change in the near end of life.
Mm-hmm.
You can look for like not David Bennett, but one of the guys, Bob Wilson studies. He's done some stuff like that.
Okay, thank you. And Michelle wrote the comment. She agrees with Alden that popularity mocha driven to being free, but it's not anymore. Yeah, so they started to charge. It's actually not that expensive. I think you have to take a test to use it. I mean, not that expensive, $120 or something, but still it should be free. So, okay. So, and then here, this was a perfect, the storm. So how clinically relevant are these tests? And I'm sure you all heard about the aducanumab, the recent drug, which was approved, or Aduhelm, which was approved for Alzheimer's disease or mild cognitive impairment treatment. And actually, you can go to the FDA website and everything is there. You can see all the data. And if you have nothing else to do on a Friday night, it's fun to read the data. And it's actually, you go to the FDA, put in aducanumab, and it's the medical data, not the statistical. Maybe the biostatisticians want to read the biostat data. So the aducanumab was approved based on the amyloid outcome. However, they also had cognitive data. So there were 3 of them: the CDR sum of boxes, the MMSE, and the ADS-Cog. So I copied it because I couldn't copy and paste from their website, but I just typed the numbers in here. So, and as you know, there were 2 studies, the 301, which was the negative study, and the 302, which that was what they based their request for approval. So the 302 study, here are the results. There were, in each arm, there were 500 participants, and as CDR, I can go a little bit forward. I can explain what that is. So the CD sum of boxes is derived from information collected from the informant as well as the subject through interview, and 6 domains are used to construct an overall score: memory, orientation, judgment, problem solving, community of affairs, home and hobbies, and personal care. And the CDR sum of boxes can be, you can score it. 0.0 is no impairment. And then you go up to, questionable MCI, mild, moderate to severe dementia. And it's not used in a clinical setting because it's time consuming, needs training, certification, and to be used by staff. And the literature quotes that to find that the, clinically relevant difference, you need to have 1 or 2 point difference. So, but here, so what they found that the placebo group, that was the baseline. And this is how the mean was after 78 weeks, 1.5 years treatment, there was decline in every group, but the decline in the high dose, that was what was improved. There was 0.39, and that was significant statistically. So, yes, statistically significant, but, clinically significant, it's 1 or 2 point. So that is when we say, okay, statistically and clinically. So let's go to the next slide, the mini-mental. So we talked about, so baseline mini-mental was around 26. So these were people with MCI or mild cognitive impairment, or mild AD. And over 1.5 years, they declined 3 points or 0.7. And the difference between the high and the placebo in a mini-mental was 0.06 point in the mini-mental. Again, it was statistically significant. But man, I don't know. And then was the ADS-COG. I show you ADS-COG. It was developed basically for, and it's used, it's a very brief neuropsychological assessment frequently used in randomized controlled trials, considered as a gold standard to address treatment effect. It has different targets, for treatment, attention, concentration, planning, executive function, verbal memory, nonverbal, and praxis. Again, we don't use it in a clinical setting. It's time consuming, you need to be trained. So it's called ADS-COG. It was the baseline was in all groups around the group, baseline around the same, plus 21, around the same. Again, they decline, 5, 3, and the difference was minus 1.47. Again, very little and 0 point statistically significant. So, we need to keep everything in mind in terms of, yes, it's statistically significant, but how can we translate it in the clinical world and for the patient in terms of clinical relevance? So I see a chat. Let me just see that before I draw my conclusions. Emma? Yes. Yes, there is a lack of this trial, racial diversity. Yes, it's also, you can look up, it's very nice. They have all everything there's there for both trials. They had very few African-Americans, very few Latinx in their population. Go into the website. It's fascinating. You see all the data. The other interesting, what was also, well, I can talk about, if anyone wants to talk about this trial, that's another talk, but this was very fascinating. Thank you, Emma, to pointing it out. But coming back to my hardship in the real world. So for screening, for basic clinical practice, so for the future generation, there's a lot of work to be done. We need tools. So we have imperfect tools. I think there's still a lot of work to be done. We need better ones, but they need to be brief, easy to use with high sensitivity, specificity, which can be used in people which don't have any socioeconomic and education bias. And I learned a lot from Jennifer and Barney so which can also accommodate visual and hearing impairment. And similarly, treatment effect, we need tools, maybe separate tools. Similarly, they need to be brief, easy to use, need to have high sensitivity and specificity, and need to be clinically meaningful. And again, should accommodate people with visual and hearing impairment. I need to point out that when we have patients where I am in, I have issues or I'm not sure, we have that opportunity that we can send them for a very detailed neuropsychological evaluation. However, this is the real world. We are lucky here at Hopkins, we can order them. In the real world, it's much more difficult. However, insurance does not always cover that. So they can cost up to $2,000. So there's a financial aspect if insurance will pay it. And it's not easily accessible. I'm lucky again because Hopkins has it available. We are in an academic setting. The other thing is, again, I told you in the research world, I have a multidisciplinary team where we do dementia adjudication. In the real world, sometimes it scares me, but I'm the person who eventually makes a diagnosis based on imperfect data. But we are lucky in this academic setting because we have memory clinic meetings where we have discussions where we can discuss patients, and at least I have a little support system where we can discuss patients where I don't feel sure about the diagnosis. So on this note, any more questions, comments, suggestions? Thank you for your attention and good questions, comments.
Thank you, Sevil. That's
Thank you.
excellent. Does the teddy bear, like, I'm kind of thinking you're going to be the one to take the teddy bear's eyes or open up his eyes to a better world. Do questions from students? There were some great paper recommendations shared on the chat.
So one thing the teddy bear does remind me of, and I don't know, you probably intended this, Sevil, a lot of these tests, like the individual items in the MMSE or the MOCA or whatever you call your screening test, these items come from, they are as old as the old Stanford Binet intelligence tests that we would give to like 3 and 4 and 5-year-olds, and then we would see how they were performing relative to their age, and then you would divide their performance by their age to get their intellectual quotient. Like, to ask somebody, what day is it today, or can you subtract 7 from something, like that's what we used to ask 4-year-olds. And this is how these items were borrowed, and this is how we assess, awareness and dementia nowadays in older people.
Yeah.
I think I'm left wondering what you do with this information, or what you do in the information in the clinic after completing the assessments. What are some of the recommendations that you provide to the family or to the patient?
So the question was here in the room. What do we do with this information in the memory clinic after what recommendations? So if, what do you mean if someone has impairment or, okay. So if someone is diagnosed with memory impairment, then definitely that's a hard discussion. Then we discuss that there's a diagnosis. And then if the patient, first we see if we have enough information, if they need maybe blood work to make sure if there are reversible causes, or they need also imaging to confirm, if they haven't had any brain imaging, we at least do that. We do brain imaging and do blood work. And then we discuss, the diagnosis, explain what could it be, and then do they understand what it means? Then And then the next is, what the understanding is, then potential prognosis. Then they have a lot of questions, what their priorities is, or are there safety concerns, are there legal issues, are there behavior issues, do they want medications, do they, so there are a lot of host of issues. It's never just one visit. It's never one visit. So the first one is just to find, do you have dementia, yes or no? And if it is, then definitely there's a lot of follow-up to tie in many things, to talk about many things. Yeah, I always ask the family, what is the most important thing you want to talk about today? There's what is the prognosis, or they came here because there are, many accidents, or they got lost, or, they spend money, or anything, whatever the most important thing is. And that is what we can address. It's the time limitation also. And then we go down the road, what is, step by step. And but it's, it's a process.
Would you say that people that are coming to the clinic are probably among those that are more severely cognitively impaired already? No.
People are actually, I have to be honest, people are much more aware. There's so much which is good nowadays. People are, there's so much talk about memory loss. There's so much awareness, and people have family members there where I see well-worried people, and I tell them it's okay that you came because they have family, their mother had it and they forgot something and now they think they have Alzheimer's. So the question was that, do we see people more in advanced stages when they come to the clinic? And no, we see every stage. We see people who are normal aging, and we see people, sometimes we see people who already have a diagnosis, but they have behavior issues, or they come to us for resources, but we see every stage. So yeah, every different stages, yes. So.
Sevil, this is Richie.
Yeah,
Hi.
thanks for joining.
Yeah. You focused on dementia, yes or no, and obviously it's a slippery slope and so on. You talked about differing sensitivity and specificity and so on, but in our experience in ERIC, where we wanted to develop criteria that corresponded with agreed upon criteria, we found a real lack of agreed upon criteria. And for example, we had some very well thought of consultants, and we said, well, first of all, let's assume we have a normal for the age and education level. How much below the normal does it have to be the level which you would call impairment? And our experts didn't agree on whether it was 1 standard deviation or 1.5 standard deviation. And of course, that makes a huge difference in prevalence. Not only that, but we had no agreement on to how to set the standard for our populations. We did it by various operational things. We said, well, somebody who's had a lot of decline in the past shouldn't be considered normal, and somebody that has things in the brain on MRI shouldn't be considered. And we developed our own normals and developed. But and of course, MCI was even worse. And when you see estimates of prevalence for MCI, I've seen things that go all the way from a very low percentage to, the vast majority of the population. And I think it's because clinically, there just isn't the agreement on a quantitative assessment, which will affect the prevalence. Is that your experience too?
Yes. I mean, it's very difficult to follow. I don't even know what to, even for MCI, it's very difficult. And I'm lucky because I have the research experience, so I feel more comfortable with following, adjudication, and but one MCI is very different, a definition from another one. And yes, it's I have at times difficulty, and sometimes a mini mental of 21 I still consider because of the IADL, and they're below. I mean, a mini mental 21, you would say it's a cutoff. You would say it's not normal. It's below. It's impaired, but it fits, of course. Could fit the MCI. But I cannot agree on I cannot use the same standard from one week to another. So.
And just one more observation is that in the 4 centers of ERIC, the Jackson Center scores way below the other centers on all the cognitive tests. And so how much of that is normal and how much of that is because they actually have more brain disease? And I think trying to decide that is almost impossible.
Yeah, what is
If I
considered
may.
normal? Yeah.
Yeah, this
Yeah,
is a
what is
great
considered
discussion.
normal, and yeah, sorry.
Oh, I just thought I'd add, Sevia, on the slide, different clinical issues. I think Richie's question raises the great opportunity that you're inferring. You inferred from that N of 1 with a 21. Is this inherent kind of elephant in the room, which is that education is a poor proxy. So you can have an educational level of high school, and that's what we typically do, right? You say high school or less, high school or greater, college, some college, or maybe more than that. So we have this cutoff. We talk a lot about how to handle education, but it's still interesting because we're kind of talking about culture, and we're talking around the issue that somebody with a certain demographic background, you cannot adjust for a high school level of 12 years and still account for all of the cultural adversities that one person faces relative to another. And I think that Richie's example of Jackson is a really perfect opportunity, and a study like ERIC and CHS, where you can look at different demographics and look at how people with presumably the same age, education, and race may perform very differently. But it's not because we've done a good job we're not doing the best job we can do to understand that person's background. And I think when you speak about the person with a mini mental of 21, it's clear as you talk about that person, you're getting information that goes beyond those quantitative metrics. You're clearly getting more information. And I think our challenge as epidemiological researchers is to try to understand, how do we quantify or better understand the limits and the strengths and better quantify these tools? Because we're all aware of it. We're all aware.
Yeah, and Alden just said, yeah, just people are maybe just wrong, poor test takers. Yep. that could be.
Well, yeah, I would like to think that, but I think that these patterns are predictable by demographics. And I think that we do find that Black people in urban areas tend to perform on tests less well overall. So I don't think it's an individual differences phenomenon. I think it's something that relates to their demographic and their societal experiences and their health disparities and factors that we do not yet have a neighborhood diversity factor, for example. So I do research that would suggest maybe we should have, and this contributes to a much larger body of research, but if we were to think outside the box a little bit, maybe we'd go beyond education and think like Jennifer Manley. We know that not all education is created equal, so why not quantify education better? And use neighborhood factors, for example, that are widely available by all zip codes to better quantify someone's education relative to another, not just based on number, but based on where that education was obtained. That's something I'd like us to, I think that would be great. And Jen's been a leader in that area. But again, I think it's something that when we look at our tests, none of our tests are good when it comes to those issues.
Yeah, but I mean, it's interesting because another thing what that brought to my mind, we are talking about these, health disparity and access, Baltimore City. I mean, our clinic is in Baltimore City in the middle of the Latino and African-American I can tell you, we have maybe 2% Latinos in our clinic and maybe 10% African Americans. So why is that? It's maybe a culture that we don't assume that dementia is not, memory loss is not a disease, could be, or maybe access. So, or maybe we see them when they're more advanced. When I see more often, when I see the African American patients, they're usually more advanced. So when I see them, so maybe that is also, I don't know. So it's interesting. So, all these different aspects. It's just folklore. I haven't looked really at the numbers, but when I just think back, when I see these people, but I have very few Latino people in my clinic, and we are in the middle of they're all around Bayview.
That's very
So-
brilliant.
One
Will,
thing I
really?
really like about your presentation, Sevil, there are a couple of things that you said that clearly are from the clinical perspective, and I think they're likely to be absolutely right. One of them is that you say you pay a lot of attention to the informant. And the other one was that you said you pay a lot of attention to what is it that worries the family. Because the informant really knows whether the mother is different from usual, whether there has been a change in her ability to do things or something much better than we do from giving her a test which may be not so relevant. And also, as you say, if you ask the family, what is it you're concerned about? Well, mom got lost, what am I going to do? I can't be home all the time, and so on. And so as a clinician, you have to direct your attention to those things. And that may be even more important than dementia yes or dementia no.
That's a great comment. I just want to give us time we're about 2 minutes before we hit 4:30. And that maybe someone wants to ask one more question related to what Richie just shared as well about, the value of informants and the clinical acumen. Or any question you would have or comments you have from your own experiences, perhaps. And maybe it bears mentioning at this point that you're all aware that Dr. Yasar offers herself to us as basically she leads the practicum component of this fellowship, which has just been a wonderful opportunity for all the students. I can speak from my own students' experiences. It's really such a wonderful opportunity that you all have and should capitalize on, to see her in action, to actually see how she does what she's described. And as Richie said, you really do learn a lot through the experience of the patient and the informants about what matters to them. So, so that is important. Everyone has that opportunity through this fellowship. Dr. Yasar, did you want to say anything further as we close out?
No.
Any other thoughts?
No, I think, no, nothing, not now. So good points. And yep, sorry, my brain is done.
Thank you so much.
Thank you, guys.
Thank you. Let's just, I guess, give you a hand for a great, clear
Thank you for your
presentation.
time. So, thank you.
And I'll pass to Brian. Is there anything else we should, I guess, we'll probably just close out at this point, or?
No, I don't think so today. Thank you again, Sevil. It's a wonderful talk.
Thanks, everybody.